23 abdominal emergencies. So from your anatomy class, you probably hopefully remember that there's solid organs and there's hollow organs. Be a good idea to remember which one is which and what they do and the risks to the patient if they rupture a solid organ versus a hollow organ. But these organs are contained in the perineum. And the perineum is encircled by this visceral and parietal pleura. It's kind of like a baggie within a baggie, essentially. Behind all of this, in the retroperitoneal cavity, is your abdominal aorta as well as your kidneys. And they're also encased in a glad bag, between a glad bag, so to speak. It's a really important concept. You understand that these two organs, the visceral and parietal pleura, the visceral pleura adheres to the organs themselves or around the organs, and the parietal adheres to the inner wall of the abdominal cavity. And even though these two organs touch, and there's a viscous fluid between them to allow them to slide freely, there's no direct connection or transmission of information. Also, it's important to remember that the visceral layer itself and the organs themselves have no pain receptors. The parietal layer, the outside layer, is very rich in pain receptors. And the reason I bring this up is because usually when someone calls 911 due to an abdominal problem, it's more than likely going to be a pain-related complaint. And by listening to what they say, how they describe their pain as you're going through your OPQ or ST assessment, you might get a good idea of what might be going on in their abdomen. So there's two general types of abdominal pain that can be described. One's visceral and one's parietal. Visceral pain is usually because the organs themselves are inflamed or swollen. I'm sure you probably had a really bad stomach ache after eating the wrong food. Maybe you had really bad gas and your stomach distended and it pushes out on the visceral layer. And obviously the stomach has no pain receptors, the visceral layer has no pain receptors. But because of this stomach pushing out on the visceral layer, it indirectly pushes out on the parietal layer. And it stimulates pain receptors on the other side of this membrane. And because it's this general pushing sensation, what you get is a dull, achy, bellyache kind of feeling, and it's not pinpoint. It's kind of spread out through the abdomen. It's very diffuse. If someone says I got a bellyache, they're kind of going to point to a generally large area in their abdomen somewhere. Again, this is the organs that are swollen or distended for one reason or another. Parietal is now that, let's say there's an organ that ruptures and there's blood leaking out into the abdominal cavity, or a hollow organ that ruptures and bacteria has leaked out into the abdominal cavity. And what happens there is a little different. So now what you're getting is like an irritation caused by those two substances, and it causes an irritation, and it causes the pain to be very sharp and localized. So when someone has a bleed going on inside their abdomen, or they have later stages of appendicitis, they can point with one finger to exactly where it hurts. And that's because they have this spilling out of bacteria. It's irritating the lining of their peritoneum, and it's localized to that irritation. Now, there's all these different conditions: peritonitis, cholecystitis, all these we're going to talk about them pretty briefly here. Itis, of course, is inflammation of the peritoneal cavity or peritoneum. This is probably caused by a hollow organ rupturing, or it can happen sometimes post-operatively when the person has just gotten out of abdominal surgery, and a couple of days later, due to poor, treatment in the surgical suite, they develop a bacterial infection in their abdominal cavity. And this starts out as, because it's a bacteria, it's very sharp, it's very pinpoint. They get the belly, because it irritates the lining of the abdomen, the belly, you go to touch it and it's hard as a rock. It's very rigid abdomen. They'll have a fever with this. They'll be vomiting. Usually we don't encounter these too much in the field. These are more in hospital things, but you could encounter one. And listen to the story. More than likely, they have some kind of abdominal condition. They could have possibly ruptured an organ, or they've been in surgery, let's say in the last 5 days or so, and post-surgically they have this infection from that. Now, appendicitis. Appendicitis, there's your appendix. It's in the right lower quadrant. It kind of hangs down from your ascending colon. This normally stores healthy bacteria, and it helps to keep our flora and fauna kind of intact in our gut. But once in a while, in certain people, especially young male, like 20, 30-year-old range, they will get an impaction of feces in there, and it will cause an infection. And when this thing inflames, they're going to start having discomfort. So if you think about it from that visceral and parietal pain perception thing, initially this organ will swell up and distend. So in the beginning of all this, the patient is going to start experiencing a dull pain. And that dull pain is kind of localized, meaning it's kind of somewhere in the area of his belly button. They're going to point to the area. It's kind of dull. It feels like a bad tummy ache right behind his belly button. But then through this process, hours later, when this organ swells to the point where it ruptures open and it spills out bacteria in that lower right quadrant, at that point, the pain's going to shift down to that lower right quadrant, and they're going to be able to take one finger and go, it hurts right here. So now that bacteria is irritating the lining of the perineum, and it's causing that pinpoint pain and sharp pinpoint pain that they're experiencing. So you can see how it can kind of transcend from one to the other over a period of time. Signs and symptoms: belly pain, fever, loss of appetite, and again, they'll point right down to the lower right quadrant when that thing actually starts to rupture. You can always ask them, do you still have your appendix? And if they say yes, it's a good chance they're having appendicitis. Pancreatitis, so we know what the pancreas does already. It secretes those hormones that keep our blood sugar normal. This does happen. It happens for men and women as well. It's usually associated with diet. People who eat a big fatty diet with lots of alcohol, they had like 12 hamburgers last night and 3 orders of French fries and a couple of pitchers of beer, and then they had a Diet Coke on the side just to keep things stable there. But they're going to develop a stomach ache, and it's going to be in the upper right quadrant usually. This organ's like right behind the liver, so it's kind of in the same area. They're going to have nausea, vomiting with this. They're going to be miserable. They're going to be sweating. It's very painful. The vomiting can lead eventually to dry heaves that they can't control. Treatment is going to be just controlling the airway, getting them on their side to prepare for suctioning if they need it. But they're going to be stable otherwise. So they're not going to be any super serious complications with this other than they're just miserable. Cholecystitis. So cholecystitis, this is your gallbladder. So this is inflammation of your gallbladder. That green thing in the picture right there, that's a hollow organ. It stores bile that's produced by the liver, and bile is used for digestion. This organ does get infected. It does inflame. It also gets, the bile ducts get blocked by stones and things like that, and it backs up, becomes distended and inflamed. This condition is predominantly found in females, though it can still happen in especially overweight males. Usually you're dealing with females in their 40s or 50s with this. There's the 5 F's, so it's fat, fertile, 40, flatulent, and fair. So these are overweight females in their 40s or 50s. They're still of childbearing years. They still have children. They're flatulent, meaning they have gas, and they're fair-skinned. They're light-skinned people. So this is the most common demographic of this condition. Starts off slowly, and they become really miserable. They're throwing up, and what they throw up usually is bile. And bile is kind of a green, slimy substance. And you might be asking them, what have you thrown up? And they say, well, I threw something up, but it's really bitter and tasting. If it's really bitter tasting, that's bile, essentially. And you can see from the picture up here, this condition can have what's called referred pain. So even though the condition is, or the actual pain site is here in the upper right quadrant, and because the organ is distended, it is pushing on that visceral layer, and it's going to be a big dull ache that they're going to feel. There is a nerve that runs down alongside the gallbladder, and when the gallbladder swells, it pushes on that nerve, and it sends a message up to their right shoulder. So they can have a bellyache, and they can also have shoulder pain with this as well. It's kind of a tell for this type of thing. So referred pain means even though they have pain here, this isn't radiating pain, it's referred. It's two different locations that hurt. They're not connected in any way by radiation. Treatment is about the same thing. Take them to the hospital, watch their airway. They're miserable, and they'll take care of it at the hospital. Gastrointestinal bleeding. So there's two basic types of GI bleeds. You have upper GI bleeds, and this is usually from an ulcer. And when a person has a bleeding ulcer, that blood leaks out into the stomach, and then the stomach mixes it with the acids in the stomach. It curdles it, and eventually it turns it into this black substance. It's called coffee ground emesis. It kind of looks like, if you've never seen it before, it kind of looks like, imagine if you went to 7-Eleven and you bought a Slurpee, like a raspberry Slurpee. It's that same consistency, that same granular consistency, except it's in black in color with these red spots on it, essentially. And they throw this stuff up because it irritates their stomach. Lower GI bleeds are usually something that happens in the large intestine more than likely, and something like maybe they're having Crohn's disease attack, or maybe they have colon cancer, or maybe they have some type of other disease process, and they might be passing stool, and it might be bright red blood in their stool. It's still very much of a concern for us, and for them too as well, but probably not as dangerous as an upper GI bleed. Also with the upper GI bleed, some of that blood winds up going down into the small intestine. It passes through the small intestine. It goes into the large intestine. And the large intestine turns it into all these red blood cells, all these dead red blood cells are compressed into a very small kind of semi-formed stool. And it comes out as this black tarry stool, kind of a tar look and tar kind of consistency. And this is called melena. And it's really stinky, and you can't miss it. It's like someone dropped a stink bomb in the place. But if they're passing, they can have both. They can have coffee ground emesis coming out of their stomach, and they can have this black tarry stool as well, because their GI tract has processed these red blood cells and turned it into stool. These can be life-threatening. So GI bleeds can be life-threatening, especially when we're talking about ulcers. So this is what an ulcer looks like. This is a crater in someone's stomach. It happens a lot with alcoholics, because alcoholics, they drink their breakfast, they drink their lunch, they drink their dinner, they don't eat anything solid. And so consequently, all that extra stomach acid that's not normally that's normally diluted by the food eats away at the lining of their stomach, and eventually they create these ulcerations, and they can bleed a lot, even to the point of needing blood transfusion. So they're going to have a stomach ache. It's going to hurt. They might say that if they drink milk or eat food, it gets better. But if they're throwing up, coffee ground emesis, and they're passing black tarry stools, they really need to go to the hospital, and more than likely going to need some type of blood replacement. Intestinal obstructions. So I know some of you might have had the misfortune of being constipated at some point. This is constipation times 100. So now you're dealing with an impaction. So this thing's not coming out on its own. It's a large lump of stool that's rock hard and it's stuck somewhere in your intestine, and these people cannot defecate. And really is life-threatening because, as you can see this diagram here, if this obstruction isn't relieved, that part of their small intestine or colon or whatever has been affected can rupture, and that feces can spill out into the perineum, causing peritonitis and sepsis and then death. So if someone says, I haven't pooped for 5 days or 3 days, that's actually a serious condition. Now, hematological emergencies. So anemia. Anemia is essentially a decrease in red blood cell volume in the bloodstream. And this can be caused by a number of things. Females will become anemic when they go through their period every month. Elderly women and males actually become anemic due to the loss of what's called the intrinsic factor. So when you get older in your 70s and 80s, you normally, when you eat food, you take in food, your body's able to process the vitamin B, and vitamin B is used to make red blood cells, and so they don't have what's called the intrinsic factor that completes that process. So they're really low on vitamin B. I think it's vitamin B12, if I remember, and so they cannot produce enough red blood cells. And this is chronic condition. If it's not treated, it's not recognized and treated, it can cause everything from early onset dementia to brain damage to all kinds of really bad conditions because they're hypoxic. So again, this is going to be it's a simple fix. They just need a shot of vitamin B. Again, I think it's B12 as I remember. Sickle cell anemia. So this person has this condition. I believe that it's usually people that have had a malaria shot or shots at some time in their life. So people from those countries that have that condition, India, parts of the Far East, probably Central America, South America, Africa, those areas predominantly you see with this. And then at some point, not everyone gets this that has had the shot, but some people, because of the way the medicine works, I guess, it's trying to protect the blood from the disease. So it turns us into these normal round blood cells turn into these sickle cells, these C-shaped cells. And when they're in that C shape, they cannot carry oxygen, and they're more prone to clumping together, to creating clots in the person's body. And so they go through these very painful sickle cell crisis events. And their joints hurt, and their chest hurts, and their back hurts, and they've got a headache. It's incredibly painful for them. Not much you can do. Put them on high flow, 15 liters per minute. They're going to need that extra oxygenation no matter what their saturations are. Put them on high flow, get them to the hospital, and they can treat them at the hospital. Hemophilia, this is when the individual has a blood clotting impairment. So somewhere in the clotting cascade, one of the mechanisms, one of the steps is failed. So if they cut themselves, they do not develop a clot. It's not that big of a worry. If this is an external bleed, like a cut finger or a cut wrist or a cut thigh, if you as an EMT can get to that wound and put direct pressure on it, or even a tourniquet, whatever works, you can stop the bleeding. So you can still stop the bleeding. It's just basically fluid flowing through a tube. So if you can clamp the tube, you can stop the bleeding. Where this becomes dangerous is if it's an internal bleeding in the abdomen and the brain and the chest cavity, because obviously we can't get to those bleeds. When they get to the hospital, I believe that the doctors will give the patient vitamin K, and that helps to temporarily create this clotting effect and complete that clotting cycle. Just really generally for abdominal emergencies, it really comes down to position of comfort, controlling ABCs, which means oxygenation as necessary. A lot of times patients will not be able to tolerate oxygen. It makes them nauseated. So, if it doesn't work for them and they don't need it, then that's cool. And then suctioning and those kinds of things. And again, our job isn't to diagnose. Our job is to say, yes, this person's having this abdominal emergency right now. Let's treat him symptomatically and get him to the hospital so a doctor can decipher what's going on. Remember, there's a dozen organs in your abdominal cavity, and who knows, which one's going off today. Gynecological emergencies. So sexual assault, it's a terrible, terrible thing, and I go on sexual assaults pretty frequently. I do have to say, though, unfortunately, predominantly females suffer this, but I have been on a few patients in my career, males that have been sexually assaulted. I had one gentleman who was roofied, and then he was raped anally many times apparently, while he was unresponsive or unconscious. I had another male who was sexually assaulted, anally penetrated with a broomstick or some type of wooden pole. So it does happen to males. So whether you're dealing with a male or a female person who's been sexually assaulted, you're dealing kind of with the same thing. You're dealing with embarrassment, and they feel like they're dirty, and they feel like they've been emotionally as well as physically assaulted. And so a lot of what you're doing for this person is helping them kind of work out their emotions. And even though we're not behavioral specialists, we can start at this point and we can talk to them, because a lot of times they think it's their fault and they did something wrong, and it's not their fault. So the guidelines really will come down to is if they have physical injuries like lacerations or abrasions or some type of physical trauma, they need to go to emergency room to be evaluated, have all those injuries documented. At some point, they're going to get they're going to have like a CSI kit come, and they're going to collect the evidence. Now, you want to strongly discourage the patient from changing their clothes or taking a shower, or both. If they adamantly say, I'm taking a shower, then have them take off their clothes, collect their clothes, put them in a paper bag if you have one, so at least the police will have that. Now, luckily for us, in all of these cases, usually, at least, and I can only speak for the city of San Diego, but it's pretty much universal, at least in the county of San Diego, when we get a call for sexual assault, the police respond simultaneously. So usually they get there before or even just soon after we get there. So, we can just hand them the clothing, and that's our obligation essentially for this. If they were sexually assaulted and they have no physical injuries, then the police can drive them to a hospital that is designed to collect evidence. And there's a couple of them in the county of San Diego. The police will take them there with that. If you're a male EMT and there's a female victim, if you can call in a female EMT from another unit or a female firefighter, it does help. It's not absolutely necessary, but it does help in that condition, and vice versa, I guess, if you had a male sexual assault victim. Vaginal bleeding, and what I'm talking about here is something that's outside of the normal menstrual cycle. So females will have their period by every 28 days or so. It lasts 2 to 3 days on average. Most women who have a normal cycle, they know within a couple of days exactly when it's going to happen, and so that's the normal process. This is happening outside that normal process. And so the number one cause of vaginal bleeding in a woman of childbearing years is usually going to be a spontaneous abortion. So the patient has become pregnant, and maybe she's 1 or 2 months along into her gestational period, and then she spontaneously aborts. So her body recognizes that this embryo is non-viable, that it's not going to result in a living child, and so it washes away. It uses that same mechanism to wash that embryo out, and it sloughs off the inner lining of the uterus wash away that defective fetus, or I guess it would be more of an embryo at that point in the first couple of months anyway. And the problem with all this is it's, even though it is a physical problem and they're losing blood, it's usually not, in most cases, there are some exceptions, usually not life-threatening. So our job is going to be emotional support primarily. Women, female patients who go through this, it's very devastating for a lot of them. They feel like they failed in be able to to have a child, but you have to kindly, of course, you have to let them know that, well, actually their bodies did not fail, because their body recognized that this potential child was not going to survive in the womb, and it was able to eliminate that pregnancy or terminate that pregnancy, and then the next time, there's more of a chance of it. I believe I think 1 out of every 4 first-time pregnancies end in spontaneous abortion, simply because the pregnancy is not a viable pregnancy, and it's just nature taking care of the problem. They'll have spotting, vaginal bleeding, spotting, cramping in their lower abdomen, all common things. And you just ask, well, when's your normal period? And they'll say, well, I haven't had one for a couple of months, but normally it's, the 3rd week of every month. You can kind of guess this is something going on like that. Just be prepared to help them, support them emotionally as well as physically. So scene size, the big thing on this is the barriers to assessment. I know some male paramedics and male firefighters and male EMTs that I work with. They do not deal with the female reproductive situation very well. They're uncomfortable speaking to the female patient about their issues going on right now. And like any other being in the world, if you're uncomfortable talking to somebody, they recognize that you're not doing very well, and their trust in you drops dramatically. So, as a male myself, I can never, well, what's the word for it? I can never say I fully understand what's going on, because I don't. But I can, listen to what they have to say, and based on what I know about anatomy and physiology and all that, I can understand what might be going on, and I can help them physically and emotionally. If you're one of those people who can't talk to these people freely about their condition, then you might want to turn to your partner and go, hey, partner, would you mind taking over and explaining? Maybe you could explain to the patient better about this. Maybe your partner will build a better rapport with the patient, get more information, be a more comfortable ride to the hospital with the other person. Physical examination, of course, it really should be limited to only what you have to do. I mean, if a woman says, I'm spotting and I have a little bit of spots of blood in my panties, there's really no reason to physically examine the area. If there's sanguinating blood, they're having vaginal bleeding to the point where they're going to die from, shock, well, then start thinking about maybe, making sure what was going on down there. So sometimes you do have to do a pelvic examination on these patients. Patients having, they're going through childbirth, and they're in their 9th month and their 3rd trimester, and they're having contractions every 30 seconds, and you're going to have to look and see if the child's crowning. So there's certain cases you do need to do a physical examination. Other cases, you can withhold. Just you got to make your own decisions on this. So urinary tract infections, UTIs. Predominantly females get UTIs, and they're usually isolated to the bladder themselves. Men do get them occasionally, but unfortunately they get really sick. They get high fevers, and they spread to their kidneys and all kinds of complications. This is the anatomy of the urinary system. So you have the kidneys, That's those kind of like bean-shaped things up there that look like they have yellow blonde hair on. And actually, that yellow blonde hair, that's your adrenal glands. This is the retroperitoneal cavity. This is behind the anterior cavity that holds your other organs. And the kidneys, they make urine. They filter your blood. They draw off ions. They draw off the extra fluids as you don't need. They draw off the blood cells, and all the waste products in your body get basically passed through the kidneys, the nephrons of the kidneys, and their urine is then produced. It goes down those kind of funnel-shaped blue tubes and into your bladder. And your bladder is a muscle, and it stretches as the urine comes in, and it gets to a certain point. It stretches far enough. It sends out messages to your brain that it hurts. You've got to pee. That's your message to pee. Women have one sphincter, so they open a single sphincter and they urinate. And guys have two sphincters because they have a prostate gland, and they have to open two sphincters, one after the other. And of course, this is one of those kind of, you just relax, and it does happen usually. And then the urine passes out the urethra, and all is good. There can be some complications with this. Kidney stones are one of them. Kidney failure, there's chronic and acute kidney failure. And a lot of elderly men, older men in their 50s, 60s, 70s, 80s, they have prostate gland problems, primarily enlargement of the prostate due to the aging process and their hormonal changes. And unfortunately what happens with this is due to the enlargement and swelling of the prostate, it can reduce their urinary flow to even to the point where it stops, which can be very serious because the urine will back up, and they can have bladder infections with that. They can even have kidney infections. And if it lasts long enough, they can actually go into kidney failure too. So when someone says, I haven't peed for 8 hours, that's a serious condition, and not to mention a painful condition. Here's kidney stones. These are formed in your kidneys, and we pass them all the time, little microscopic ones, the size of little tiny, like ant-sized little ones and smaller. But occasionally, if you're that individual that's prone to it, you're going to create this really big thing. And it's relative. I think most kidney stones are around 3, or the ones that we pass anyway, the ones that hurt us anyway, 3 to 5 millimeters. Usually that's about as big as they get. But they're very agonizing. Imagine one of these things break free, is like in the picture here, like the agony one breaks free, and it's going down your tube. And as it's going down this tube from your kidneys, it's like literally a cat going down a curtain, it's claws in the curtain, and as it's going down the wall, it's just ripping the wall of this tube with the sharp edges. And this is why people get that pain, and this is why they wind up getting the blood in their urine. And every time the stone moves, it's agonizing. And when the stone comes to a stop, they feel better. And then the stone starts moving again, and it's agonizing. So they go through these phases of these. The stone will go down an inch and stop, and go down an inch and then stop, and all the way on. Eventually, it passes out through your urethra. You pee it out. But signs and symptoms are going to be flank pain. So basically, pain about right where the kidney would normally be. It wraps around down your abdomen into your groin area. It hurts to urinate, and there's usually pink urine, or just blood coming out when you urinate. Those are all signs of possible kidney stones. Now, kidney failure, the most common cause of chronic renal failure is diabetes. And these people have no urinary output, or very, very little, like less than probably 10% or so, and they need dialysis to stay alive 3 days a week. Occasionally, people will go through what's called acute renal failure. And this would be a most common reason, and I know you guys already had your shock lecture, but when people go into decompensated shock, they start to develop into that decompensated phase. But one of the things the body does is the body starts to shut down the kidneys to retain whatever fluid they might have in their body to keep this person alive. So this person is a critical trauma patient. and the kidneys shut down. You get him to the hospital, the doctors do surgery, they reperfuse this patient with blood, and he survives. But the kidneys are still shut down. They might take weeks or even months for them to restart after this event. In the meantime, they're going to have to get dialyzed until the kidneys start up again. So what they do is they put some type of central line in, usually some type of central line like a Gershon or Hickman catheter. You'll see it in their right around their chest, around the subclavian area on their chest, maybe like the second or third rib area right there. And we have 2 or 3 of these little pigtail tubes coming out, and that is a dialysis catheter. And they'll be dialyzed through that catheter temporarily until their kidneys regenerate, and then at that point they'll take it out and they'll be back to somewhat normal status. Chronic renal failure, unfortunately, when they first recognize this, they'll put the same catheter in their chest, but while that's being used, what they're going to do is they're going to insert a shunt into this person's non-dominant arm. So if you're right-handed, it's going to go in the left arm and vice versa. There's 2 ways of doing this. One, they can use an artificial graft. So it's like a Kevlar or something like that. It's an artificial tube, and they graft an artery and a vein together, and then they allow it to mature. They can also strip a vein from the inside of the patient's thigh, and they can use that vein to graft and do the same thing. And it's up to the doctors how they do this. But once this is in place, they have to wait till it matures, and it takes weeks to do this. And what it looks like when it's mature, it looks like this here. It looks like this. It looks like that horseshoe-shaped thing. And that's where the needles go when they go to dialysis to be dialyzed. Now, we don't want to harm this thing because it's hard. Once you damage one of these things, they cannot be fixed, and they have to put a new one in, and it takes weeks and weeks for them to mature enough to be used. So we do not want to ever take a blood pressure on this particular arm, or else do it on the other arm. So no blood pressures on this arm. If for some reason you can't use either arm, you can always use the calf. Put your BB cup on the calf and use your pedal pulses, and it gets a fairly accurate blood pressure. But never take a blood pressure on the arm that has the dialysis graft or shunt on it. This is what it looks like. This is what a dialysis center looks like. Sitting in a chair, you have your blood pumped out and filtered for 4 or 5 hours, 3 times a week. All kinds of different complications. The biggest complication here is if they haven't been dialyzed for 3 or 4 days, they build up so many toxins in their body. They build up so much potassium in their body, they become hyperkalemic. And hyperkalemia is really bad because it affects your cell's ability to function. And the end result in this is they go into cardiac arrest. They go into some kind of weird rhythm and their heart stops if they're not dialyzed in time. So you might go on a patient in cardiac arrest and you find out from the family that they're normally dialysis patients, but they haven't, due to one reason or the other, due to the COVID thing or whatever's going on, they have not been dialyzed. And you can almost guess, it's been 3 or 4 or 5 days since their last treatment. They're probably dead because of the hyperkalemia. Lastly in all this is the urinary catheters. Just really briefly on this. So if you look at the right lower picture, you can see the tube goes up the urethra and goes into the bladder. It's held in place by a little balloon. And this person pees into this tube and down into the bag that captures the urine. This is usually people who are bedridden. They can't get out of bed. And these catheters are replaced usually every few weeks, and they're very prone to bacterial issues. So 2 really bad things can happen. One is the catheter is left in too long, so the nurse hasn't replaced it for like months, and it builds up bacteria in the tubing, and that bacteria migrates up into the bladder, causing a bladder infection. And then if it's not recognized early enough and treated, and it leads to a kidney infection, and then the kidney infection then spreads out to the whole body, and now this person's in septic shock. The other scenario is caused by us sometimes. We're transporting this patient to the hospital, and we inadvertently lift the bag of urine above the level of the patient's body. So we have this thing up above this person's bladder, and all that stale, bacteria-laden urine flows back into their bladder, and now you have a bladder infection. And unfortunately, these people are usually, when they have these Foley catheters in place, they have dementia, they have Alzheimer's, they're confused, they're unconscious, they've had a stroke, they're disoriented, and they're not going to feel the usual pain and discomfort that you and I might feel if we had a bladder infection. They're not going to go, hey nurse, it hurts to pee, my bladder is burning. They're not going to have that sensation because they pee through this tube instead, and they're disoriented, so they're not going to be able to express to the nurse what might be going on. And these get missed. These infections get missed, and they just migrate through the bladder, into the kidneys, into the whole body. This is a common mechanism that people unfortunately die from sepsis.